Welcome, I'm Dr. Robert Glatter, Medical Advisor for Medscape Emergency Medicine. Today we'll be discussing the topic of Paxlovid Rebound, which has been front and center in the news. Both Dr. Fauci and President Biden experienced the phenomenon. Joining us to discuss the topic is Dr. Paul Auwaerter, Professor of Medicine and Clinical Director, Division of Infectious Diseases at Johns Hopkins University School of Medicine. Welcome, Paul.
Yeah, welcome. I'm glad to be here, I should say. And this is a topic that a lot of patients and physicians have questions about.
Absolutely. And so I really want to start off by defining for the audience what Paxlovid Rebound is and how you would explain that.
Right. So I guess I would divide into two possible areas. One would be just people improve and then have some symptoms of recurrence, whether it's upper respiratory, even lower, perhaps fever might be one. So does the syndrome recur? The other would be for those that especially have home antigen tests in hand, where we know that measures about 10 to the fifth or so or higher logs of the virus. Does your test become negative and turn positive, or does your test still stay positive for those that haven't checked after you take a course, usually 2 to 3 days after you stop for up to a week later?
Mm-hmm. And so people that persistently test positive, and this has been a question, in terms of are they infectious? And if they're having this rebound, and let's just say they're mildly symptomatic, do you advise that people do rapid antigen testing serially day to day in order to prevent, exposing family members or coworkers or wherever they may live?
Right. So I don't know if everyone has tests for daily. I'll tell you, I had COVID the same day as Tony Fauci, and so I had lots of antigen tests. So I was antigen positive up to day 11. Did not even take Paxlovid, and I ran out of tests. So I don't know if I was positive after that. But I did try to limit my exposure, wear masks. I didn't, I worked from home and so on during that time. Of course, the recommendations are still to stay for 10 days. But I would say certainly for patients and myself, one of the reasons I didn't take Paxlovid was I had a commitment that I didn't want to miss in case I had Paxlovid Rebound, about 12 days after my illness.
Interesting. I'm glad you're doing better. That's good news.
Yeah, no, I'm doing fine, but there have been, to answer the other part of your question, was that there have been reports of transmission within households. So
Right.
not widespread, but yeah.
Right, and that speaks to the CDC's guidelines, obviously, which have been revised recently. And people are concerned about, exposing others during this period of rebound. And I think that's an important part to really, sort of dissect. And that's where the controversy exists. Should we really be re-entering society at that point?
Right. And, especially if there are vulnerable populations, you especially want to be very careful if people might be living in your household that might be at risk. I think much like the reason why the CDC practically reduced from 14 to 10 days and, just downward is that, the practical aspects are how adherent are people, how much are people actually following through on this. And yeah.
Let me back up. So can you explain what Paxlovid is? What are the two drugs in it and how does it work? And what in your mind would possibly be a mechanism that could be behind the rebound? Because I think that's the million-dollar question.
Sure. So to break it up again into two pieces, Paxlovid is nirmatrelvir combined with ritonavir. And nirmatrelvir is a specific protease inhibitor. Those of you that might have treated hepatitis C or had patients with HIV are on these protease inhibitors. What they do is they inhibit a virally driven protein that cleaves a polyprotein into specific components so you can make new viruses and assemble. Now, nirmatrelvir works, but its levels are not sufficient at the current dosing scheme. So it's boosted with ritonavir, which really has no specific activity against SARS-CoV-2, but raises the nirmatrelvir level. The unfortunate aspect is that ritonavir is a suicide inhibitor of CYP3A4, so it has a really a tremendous list of drug interactions that you want to be very careful about in patients before considering prescription.
Right, not absolutely. The drug-drug interactions are what, the people that need it most, the people with chronic medical issues, diabetes, hypertension, obesity, people that are on blood thinners for AFib or post-stroke. These are the people we're concerned about, but need the drug the most. And so, that's really, our concern as clinicians.
Yeah, that's right. In fact, the group that might be at highest risk for the solid organ transplants, they may be on calcineurin inhibitors such as cyclosporin or tacrolimus. And that's where the drug interactions, even if you hold the drug, can lead to great toxicity. You can have syndromes like posterior reversible encephalopathy. So there's very strong recommendations not even to think about prescribing it in those patients.
So do we know, or what are your thoughts about the proposed mechanisms? There's been some early research in this, and we're talking about whether this is immune related, is it circulating virus, is it some other type of mechanism we're just not aware of at this point?
I think the jury's out. Clearly, we know, for example, in myself, where I'm not taking any medication, there's some evidence of rebound, I think. I didn't have many symptoms. I just had viral carriage. I mean, I had continued improvement during that time. One theory is people now are taking the medicine very early. I mean, we're doing antigen tests very early, not later. And perhaps we're suppressing the virus so early, there's enough transcripts and so on and so forth that something builds up and you withdraw the drug and then boom, you get the rebound. The other is that perhaps you're impairing some of the earlier immune responses, and it sort of depends on what people's immunological history is. Do they have the ancestral virus? Did they have alpha? Have they been immunized? And now with BA5 especially varying enough, there's enough immune escape that maybe the body hasn't enough chance to really adapt. So by the time you withdraw the drug, there's not enough to keep the virus at bay. Those are just some of the ideas, and it may be multifactorial components, but a substantial number of people do rebound. I mean, careful studies have suggested a few percent rebound, even in natural infection, but it might be higher. Some preprints have recently suggested could be as high as 20-25% with careful analysis.
Yeah, exactly, and that's concerning. That preprint you're referring to was in early August that came out, and that kind of was very eye-opening, to be honest with you, to hear that up to a third of patients are rebounding. And these are people without taking Paxlovid or any other antiviral for that matter. Obviously, we'll bring in molnupiravir to the conversation because that certainly doesn't have the efficacy that Paxlovid has, especially in the early studies, but it is available and something that we look to in those that can't take Paxlovid.
Right. And, this may have been happening all through the pandemic, but we always knew you could have persistent virus by molecular analysis and PCR. And we sort of knew early on that for immunocompetent patients, really by day 7 or 8, it was very hard to find culturable virus. And we're now just still grappling with quality studies to see what's happening with BA5, for example. Is that different? There's a sense that it might persist a bit longer, and that may be a component here as well.
Right. The other issue is, I guess, related to testing. Could you get a false negative early on after your initial infection, then, thereafter test again and then become positive? And that certainly is a limitation of the rapid antigen testing. The other issue that I've seen is that maybe someone developed a secondary bacterial infection, sinusitis, bronchitis, pneumonia, and thought that this was, this sort of masqueraded as a rebound, and truly it's not a rebound, it's a secondary infection. So I think that's another caveat that we have to think about in this discussion.
Absolutely, and I think that may be giving a bit of a false impression that there's even higher rates of rebound, clinical rebound, after they take this, because often patients do feel substantially better quicker taking the drug. And and then there's this rebound, which may just be that some antigenic drivers are just stimulating the immune response as the virus makes some proteins which aren't being assembled into real virus, but stimulate a bit of a rebound clinical syndrome.
From what I'm seeing is that younger patients who don't really fit the category that are at high risk, that are 50 to 65, that have comorbidities, are getting prescribed Paxlovid, in urgent cares, even in EDs. And this type of prescribing is problematic, and it speaks to, indications that are for the drug, that never really, were developed for. And I think that that's important to really, stress that there is a specific group that should be really the target for these antivirals in general. And I think you would agree with that.
Yeah, I do, absolutely. I mean, the EUA, of course, says risks, and everyone looks at the CDC risks, and that's sort of become a little more liberal over time.
Hmm.
How I handle it is I have discussions with the patient, because some of them will say, well, look, I'm 54, I should get Paxlovid. But I say, well, gosh, you're doubly boosted. Chances of serious illness are really low. There's a rebound issue. But if someone's 75, they have major health problems, you're immunosuppressed, I say, look, even though you may be immunized, I would feel much better. I'd strongly recommend you take the Paxlovid there, because we do know that it can help prevent serious illness, even though we don't have, the kinds of studies yet to really suggest how well it works in these populations. But it's extra insurance. You're going to do fine,
Yeah,
and we'll deal with the rebound if it occurs, and
exactly.
give isolation recommendations at that point.
Right. So in terms of isolation, you bring up a good point. What is your recommendation, and how would that jive with the CDC's recommendation in terms of isolation with a case of rebound?
Yeah, so I mean, the clock resets in a way, right? To be cautious. So it's as if you have a second illness. In fact, the president and Dr. Fauci both got second courses,
Right.
which you could say fall a little bit outside the EUA in those cases, unless if you think they're a new infection. But I usually just advise that people do remask and try to isolate isolate during those times of rebound, because I think there is infectious virus. If they have antigen tests, if they have 2 serial negatives, I'm like, good, you can go about, wear a mask for that 10-day period at that stage. So I tend to rely on the antigen on the other side too, to try to get people out of jail sooner.
And in terms of any other aspects of viral load rebound, I think Dr. Ho, who's an HIV researcher well, had documented actually a personal case where he had been at a COVID conference in Paris, and he ended up testing positive. And he became convinced that the rebound phenomenon was really due to Paxlovid, and it wasn't just inherent as part of the actual disease itself. I think there were 10 patients in what he published. Kind of hinted at that, he really was suspicious that the drug itself was more the cause of the rebound. But again, the data is not necessarily pointing to that, and I think there is controversy.
Yeah, I agree. I think there is the impression and the focus that people will anchor to what they've last done. And
Right.
so Paxlovid ends up taking the brunt of that. But I think there is an impression, and maybe it's just the focus, and we need to do more study, to see if this is really a fair attribution or not. Or is it part of the milieu that people have now with a lot of some degree of neutralizing antibodies from immunization, infection, and so on, that offers part of these dynamics here. But I think it's probably real to some degree. The question is how much. Yeah,
So
sure.
one concern that patients have expressed to me is that they don't want an intense rebound effect. And if they take Paxlovid, that they're going to be at risk for that. They'd rather just sort of, tough it out and take, anti-inflammatories, acetaminophen, fluids, and just supportive care. And I guess some of the literature is certainly reflecting that the intensity of the rebound could be an issue in patients, especially older patients. Should that dissuade people from considering Paxlovid or another antiviral?
I still say no on that, especially for people at high risk, just with the idea that, we still have, 50 or 60 patients in our hospital with COVID at any
Right.
given time, and it's exactly these patients. And although the intensity rebound may be disturbing, it's perhaps because you feel like you're improved and
Right.
suddenly a day or two later feeling a lot worse. But again, we have not hospitalized anybody that I'm aware of with Paxlovid Rebound. I can't say it can't happen,
Right.
but certainly on the other side, we have people still coming to the hospital with this. So,
Right. And I think that's the goal, is to keep people out of the hospital, obviously, reduce complications. And the drugs are working. We know that they're working. And I think that's really the ultimate outcome.
absolutely.
The studies are ongoing with Pfizer. 10 days of Paxlovid versus 5, is really, I think, the crux of the issue, because with persistent circulating virus, especially in high-risk people, I mean, is there a downside to having a 10-day course? Are we looking at resistance? I mean, is that a concern with 10 days versus 5 days?
Well, in certain populations, it could. You have more opportunity and pressure to select for viral resistance. 10 days may be the right answer. It may be combination therapy, which we tend to use
Right.
in lots of viral infections. But this is hopefully a shorter and more and ultimately self-limiting infection, even without treatment. So 10 days may be the right amount here.
Mhm.
To try to avoid some of these more infection control oriented problems. Because I've never had someone with really terribly serious illness have to land back in the hospital and so on with the rebound, which is another aspect I do tell patients, that even if you do rebound, not to worry, because many of them are worried.
There's also, I wanted to point out a study that Pfizer ran, post-exposure prophylaxis, and whether there was any, value to, giving it to patients who were, had an exposure to someone who was positive. And the data, from what I saw, didn't really pan out, and that it didn't have any role.
Yeah.
And that was an interesting part, that they ran the study, and that, certainly there was no indication for giving it. I get your thoughts on that.
Yeah, so I mean, we know for influenza, oseltamivir, even zanamivir and baloxavir all work if you give it early enough after
Right.
exposure to a degree. I think it's also a numbers game, and especially in a heavily immunized population, perhaps the numbers weren't just big enough to really show an impact. I think it makes biologic plausibility to use it that way. Of course, with the EUA, we're not supposed to prescribe it that way currently.
Right.
Um, but but if I had someone that was a close contact who may have CLL, they can't mount antibodies, they're on Evusheld, for example, for pre-exposure prophylaxis, I would have little compunction if the drug were available to give it for post-exposure prophylaxis in a really high-risk patient, because some of the most difficult patients we've had in hospital are those that have B-cell deficiencies that have prolonged viral carriage and illness,
Mhm.
often for weeks and months at a time.
Right. And I think some of the Pfizer studies and other studies have pointed to the fact that hospitalized patients certainly are with high risk features, as you're describing, should be candidates for antivirals, especially Paxlovid.
Yeah, I think that's exactly right. And those are groups where I also use monoclonal antibodies if they're available. We're currently limiting them to severely immunodeficient patients, transplant patients, just
Mhm.
given the limited availability of the monoclonal, since
Right.
federal funding is no longer present, and doses at least are waning in state supplies.
And assuming monoclonals are available and you have a higher risk patient, would you prescribe remdesivir outpatient for a 3-day course as an intravenous infusion, if assuming there were other contraindications, especially to Paxlovid?
Yeah, so what in the state of Maryland, what we're doing is, if people aren't eligible for that, what we have a tiered scarcity level for the bebtelovimab to really target people, for example, on rituximab, people that might have CLL, people
Mhm.
that cannot be immunized, maybe that a severe reaction to the mRNA vaccine. They
Right.
get that telovimab, but for others that might be at high risk, like transplant patients, 3 days of remdesivir is what we're using in that group.
I think that, there are other options beside Paxlovid, and I think we look at that as sort of the only solution right now. Certainly as an outpatient, it's attractive, but I think that's important to hit on.
Yeah, the remdesivir just presents a logistic challenge. No one wants to come back 3 serial days
Exactly.
for an IV infusion. I mean, molnupiravir is a drug which we mentioned. It's the other oral antiviral. And the MOVE-IT trial had a 30% reduction in hospitalization or death at 28 days, again, in an unimmunized population. So its impact, I think, in an immunized population is likely less. So it's clearly second tier behind Paxlovid and monoclonals and even remdesivir. A recent secondary analysis in the annals did suggest that there is less need for less of a respiratory illness progression, and even people that did get into the hospital got out of the hospital earlier in those in the active molnupiravir arm. And the actual trial had 9 deaths in the placebo, 1 in the molnupiravir. So my sort of view is if push comes to shove, for a high risk patient, I do prescribe it because I think it does have some benefit. I don't completely discount it and say, oh, it's not worth it for patients. But I think for the 50-year-old who is doubly boosted and so on, I don't think you're going to get much juice out of squeezing that one.
Right. Some people have talked about the mutations aspect of molnupiravir and that being a concern that patients have heard about. In reality, is that something that, in your mind, should preclude physicians from prescribing it?
You know, we've used nucleoside analogs for quite a while. This is a 5-day course. I don't worry so much about the genotoxicity. The one group that I do talk to people about are men, well, women too. Women, are supposed to practice birth control for up to 4 days after they stop that drug. Men, it's 3 months. So if there's family planning going on, I might talk about an alternative, or else, that's the advice.
Got it. And I wanted to ask you if there are any new antivirals or COVID-19 therapeutics in the pipeline at this time that could even supplant Paxlovid as you see going forward.
There has been an analog of colchicine, which had some very promising impact on the hyperinflammatory phase and ICU issues. And so that has a EUA in front of the FDA right now. Right. There are other oral antivirals, and certainly the most requested one is a non-ritonavir protease inhibitor, so we don't have to be as concerned with drug interactions.
Got it. We do know that there are medicines based on a recent article, actually, that Eric Topol had put on Twitter, that fluvoxamine, the antidepressant, as well as ivermectin and metformin really have no role. Metformin possibly in a secondary analysis had some impact on primary endpoints, but overall, I think what we're learning is that there are drugs that work, there are drugs that don't work. And I think, looking at the evidence and practicing, evidence-based medicine and really looking at that is very important.
Yeah, I don't know if it will persuade the ivermectin believers, but I think the fluvoxamine, which last winter, really when sotrovimab was not available, there was no medications in the outpatient arena. We thought about fluvoxamine based on the Brazil Together trial, but I think here in a health population more like, like here in North America, it really didn't seem to have any impact. And the metformin's intriguing, but again, I don't think anyone's going to be running to prescribe that as an alternative here. So again, the repurposed drugs are great. We're learning more and more that that's a really tough hill to climb to find success when you're trying to use an existing drug to impact a novel disease.
Right. I wanted to just wrap up now, just if you had 1 or 2 pearls for our audience, just to sort of take away from this discussion.
Yeah, one is, although the rebound phenomenon, which may be due to just infection itself or related to a drug like Paxlovid, it's important, I think, that if you have a high-risk patient, please still strongly consider antiviral therapy in Paxlovid. But I wouldn't be dissuaded from that. The second aspect, I think, is know your drug interactions. We've seen people made ill by Paxlovid land in the hospital. So there are a number of drug interaction checkers. The one I like is University of Liverpool. They do a great job and have had a long history of HIV drug interaction checks with ritonavir. So I think they have very clinically sound recommendations in their drug interaction checker.
Well, this is great. Thanks for decoding and deciphering what Paxlovid Rebound is and the phenomenon of rebound in general. Really appreciate your time, Dr. Auwaerter. Thank you
Oh,
again.
well, yeah, thank you for having me. And we'll learn more because we're still trying to understand the mechanism, and I think that will help inform a little more about what's going on and what to do.
Absolutely. Thank you again. Truly appreciate your time.